Okay, welcome everybody. This is our first Pecha Kucha of 2017, summer 2017. And we have Ann Schaeffer, Caitlin Hainey, and Kristen Hayward, who are presenting with us tonight. Donald Burdine has been excused because of the hurricane coming in Florida. And we have two observers, Ardith O'Rourke and Emily Andrews from 7:30. Dr. Slager and myself, Dr. Butler, are here. So Caitlin wants to go first. So Caitlin, whenever you're ready to start, we'll all mute. And then whenever you start is when I will push the timer. So you just go ahead, okay?
Okay, I'm going to go ahead and bring my shared screen up and my presentation.
Yep. You don't have to hurry, just whenever it works for you.
Okay, I just want to make sure I'm screen sharing here.
I don't see it yet. Oh, okay. It's coming. It's coming.
All right. So I'm going to go.
There. Good. Oh, you're good. Caitlin, you just start whenever you're ready.
Oh. Hang on. Oh. Sorry, hang on. Can you hear it? Can you hear me?
I can hear you. I won't mute until you tell me to go, because then I can't respond to you.
Okay, we're going to try it. So go ahead and go.
Okay. Caitlin, we can't hear you.
Oh. Okay.
Do you want someone else to go first while you figure this out, or you think, I mean, it's there.
I think if you can give me 30 seconds, I can get it.
We can definitely give you 30 seconds.
Okay, give me like 30 seconds. Hang on.
Yep, no worries.
So does anybody in 7:30 have a question?
You're so sweet, Anne.
Ardith
and Emily, this is your chance. You got a full audience here.
I just remember 7:30 feeling really hard. So I'm just, if you know, you're
how did you get over?
Oh, sorry about all that.
Okay.
We'll come back to it.
All right. Okay, so I'm ready now. Here we go. Hi, I'm Caitlin Hainey. Thank you for being here tonight. I work both as a lactation consultant at Mercy Hospital in Des Moines and as a midwife at an area AFQHC. This presentation focuses on my doctoral nurse practitioner project, which is near and dear to my lactation consultant heart. My project aimed to increase the rate of exclusively breastfeeding moms and babies upon postpartum hospital discharge to 45% by September 2nd, 2017. This project took place at Mercy Hospital Des Moines, the largest hospital in Iowa. We did close to 500 deliveries each month. And before this project began, Mercy's rate of exclusive breastfeeding upon discharge was 30%. The Joint Commission states that a realistic goal for hospitals' exclusive breastfeeding rates upon discharge is 70%. So you can see that there was quite a large discrepancy in current and best practice. The size of the hospital itself was my biggest barrier early on. However, the administration at Mercy was one of the biggest supporters and were very open to any changes that might increase breastfeeding rates. My next large hurdle was the nursing staff. Many were used to the strict standards of breastfeeding that originated decades ago and still had not lost their cold, tentacled death grip on how babies should breastfeed. I knew that education would be key in changing nurse attitudes and behaviors, but reaching literally hundreds of nurses seemed daunting. For the first test of change, started daily huddle board-led lactation education. We had predicted that nurses would respond well to small doses of education. Our feedback was positive, and huddle education topics included frequency and length of feeds, importance of skin to skin, normal newborn weight loss, and when to consult lactation staff. I wanted to ensure at least 80% of our daily nurses were attending huddles, and the education was present at 100% of huddles. Except for 1 or 2 misses early on, we met our goals and saw our outcome of nurse confidence in these areas begin to grow. One night, our unit director was working late and came to an evening huddle. It was great to see her there among the nurses, nodding her head as the charge nurse read that day's education on on-demand feeding. The nurse could see that there was really buy-in from the top to stop controlling babies' feedings in 3-hour cycles. I knew we could not put too much pressure on the nursing staff by asking them to make many changes in a short amount of time. So many changes came from within the lactation team. One of the changes was how we engaged patients. We began to use the SHARE approach. SHARE stands for Seek Your Patient's Participation, Help Your Patient Explore and Compare Treatment Options, Assess Your Patient's Values and Preferences, Reach a Decision with your patient, and Evaluate your patient's decision. It took a few cycles, but over the entire project, our rates of SHARE use increased. Not only did we change how we engage patients, but we also changed when we engage patients. We wanted to start seeing all breastfeeding moms and see them early so that the earliest teaching and support would come from our lactation staff. We set a goal to see all breastfeeding moms within 24 hours postpartum, and our test of change to work toward that outcome was to add patients new to the MBU floor to our lactation daily sheet within 12 hours postpartum. We predicted that first, our lactation team would have difficulty adjusting to this workflow, but with a couple adjustments, including tuning into charge nurses' announcements of patients coming to the floor and changing our daily sheets, we met this goal for the outcome. You can see on the graph that as we continue to increase the moms added to the daily sheet within 12 hours, our percentage of moms seen by lactation in 24 hours increased concordantly. Last, we introduced a paper feeding tracking tool. We predicted moms would use it to help track their feedings, but they didn't seem to want to use it. By changing the tracking tool from an 8x11 sheet of paper to a simpler, more aesthetically pleasing postcard-sized tracker, our rate of use did climb to 35%, though still well below our 60% goal. Still, our other tests of change, especially our continued nurse education and lactation, helped us toward our aim. Our goal was to have 45% of babies exclusively breastfed upon discharge. Our median ended up slightly higher than our goal at 46%. During our last PDSA cycle, we were at or above our goal each time we measured our progress. One of the biggest takeaways was how small changes can make a big difference. At one point, we were pretty sure SHARE teaching was being used more than was being documented. So we simply put up reminder signs to document SHARE approach on all the lactation office computer monitors. It's funny because I expected this change would really help the other LCs, and it did, but it really helped me as well. The other big takeaway is that to change a system, you must start with the education, and it must be from the bottom up. Focusing on educating our nurses on lactation norms was the single biggest factor in this project's success. Nurses have by far the greatest amount of patient contact, and their learning from huddle was cemented and actualized when they in turn shared that teaching with their patients. I like to think the outcome of this project is sustainable, but to be so, it needs to be a true team-driven norm. As I transition more into a midwifery role, I do not plan to stay here as an lactation consultant. So the lactation team will continue the nurse education and use the new infant feeding tracking cards and updated daily lactation sheets. I will encourage everyone to continue to use the SHARE approach and advocate for seeing breastfeeding moms as soon as possible. We have a lactation team meeting next week, and I hope to get input on sustainability and tests of change. In reflecting on my project, I was very nervous about the barriers that I had discussed above. But I see so many factors that promoted the success of this project as well. These include strong buy-in from the administration, which helped the nurses relax and buy in as well. The willingness of the lactation team to step up and change many things that had been done one way for a long time, and the willingness of nurses to change. I see myself growing as a leader throughout this project, not only because I decided to spearhead a giant change, but because I got right in the thick of it with everyone else. Kind of like Mel Gibson in Braveheart. I was scared, they were scared, and to lead, I had to be right there out in front, fighting just as hard as everyone else, and that is how leaders inspire. I thought I could, so I did.
Okay. Oh. Okay, thank you. That was great. Let me just write my notes. Give me 2 seconds. You are 6 minutes and 37 seconds. I think you ran to get something because you were so out of breath, but then you kind of got on.
I know, sorry about that.
That's okay.
I was really out of breath at first.
That's okay, that's okay. All right, great. All right, deep breath, good job. Who would like to go next? Ann, Kristen, Ann. A lot of choices here.
I'll go.
Okay, Kristen, you're on. Same thing, Kristen, just tell me when you're ready.
Can you see my screen?
Yes.
Okay, I'm ready.
Go ahead.
My name is Kristen Hayward, and my project is on improving patient-centered weight management care utilizing a self-management goal worksheet. The prevalence of obesity has tripled since the 1980s, and patient-centered care strategies such as motivational interviewing and goal setting can prevent and treat obesity. My aim is to increase the percent of women receiving patient-centered weight management care by 50% by September 1st.
I'm sorry.
That's okay.
Somebody needs to mute because we have a child screaming in the background.
I'm so sorry.
That
was me.
That's okay. Kristen, why don't you start over so you can be on a roll here? I'm sorry to interrupt you. I just didn't want that tape to be not so that you couldn't hear it.
Okay.
Okay, go ahead whenever you're ready.
My name is Kristen Hayward, and my project is on improving patient-centered weight management care utilizing a self-management goal worksheet. The prevalence of obesity has tripled since the 1980s, and patient-centered care strategies such as motivational interviewing and goal setting can prevent and treat obesity. My aim is to increase the percent of women receiving patient-centered weight management care by 50% by September 1st of 2017. My clinical site is a small practice in rural Maine, and my partner midwife saw obesity as a growing issue that needed to be addressed. I used an SBIRT framework. Plan changes tested included team education on motivational interviewing with team building activities, BMI and family history screening, self-management goal worksheets, an EHR form to document motivational interviewing, stages of change, and the 5 A's, referral to dietitian, and follow-up with midwife for weight management counseling. I predicted the following. Team engagement would be challenging. The goal worksheet and EHR form would need editing after the trial period. Team huddles would increase the percentage of women screened and percentage of women completing goal worksheets. Women will be engaged with the goal worksheet, and interest in seeing a dietitian would be determined. After some successes and failures by PDSA 3, 88% of team members were involved in the team activities. Activities over 15 minutes led to decreased participation, so I kept them to 10 minutes or less. Lunchtime was most effective time. I decided I needed an incentive to increase team engagement. After racking my brain, I finally had an aha moment. My husband is a lobster fisherman, so I asked him to donate lobsters for my project, which he was happy to do. I used the lobsters for a raffle, and this increased team participation and excitement immediately. Using a sample template from the Joint Commission, I developed a self-management goal worksheet for patients to use as a weight management tool. I posted a completed sample worksheet in each exam room as a guide. I received great feedback from patients using the tool, and even one dad asked me if he could fill out one for himself. It wasn't until the medical assistant started introducing the worksheet that I started seeing consistency in the percentage of worksheets being completed. I initially wished I had asked the MAs to start introducing the tool from the beginning of PDSA number 1, but then realized their motivation and excitement about the tool grew over time. Daily morning huddles were also key. Women with a BMI of greater than equal to 30 were referred to our dietitian. The referral was the easy part. Getting women to the appointment was challenging. Barriers included time, money, and transportation. I noticed that gestational diabetes is a motivating factor to see the dietitian. I started midwife follow-up calls as the new test of change and found that women were answering the calls. I am still waiting for this week's phone calls to add the last point on my run chart. Summary of results: staff engagement was high with a brief team activity during lunch with a lobster raffle incentive. This also improved EHR weight management counseling documentation. The percentage of goal worksheets completed was high with the MAs introducing the tools and with the morning huddle. Screening with BMI was maintained at 100%. Family history screening form completion was high with the implementation of a team huddle. Getting women to see a dietitian was very challenging, but women were open to a midwife follow-up phone call and found it helpful. Team satisfaction improved with the implementation of this project. I learned that positive and effective team engagement drives process change. By the end of PDSA 4, the percentage of EHR documentation of motivational interviewing, stages of change, and the 5 A's was 100%. I learned that most of the team can be reached with a short team activity during lunch with a lobster raffle incentive. Team satisfaction increased from 77% to 88% over the course of the project. I learned team huddles at the beginning of the day improved communication, team building, and team engagement, which led to 100% of women screened and 100% completing self-management goal worksheets. The percentage of women confident in weight management increased with the goal worksheet. I learned women are answering the follow-up phone call, and qualitative data reveal they are finding the phone call helpful. I learned that even with an automatic referral and dietitian appointment, it continues to be difficult getting women to see the dietitian. Project impact on the local system was greatest among the team. We learned about each other, relationships grew, communication became more effective, and as a result, patient care improved. Team engagement and building strategies can be implemented in any setting, and these findings may therefore be generalizable. Project impact was also evident among patients, and that they were the quality improvement drivers. This was imperative to the project's success. The project is sustainable for most measures. The self-management goal worksheet will continue, and the MAs will continue to introduce the weight management tool. Team huddles at the beginning of the day will also continue, because this improves communication and team engagement. Women will continue to be screened with BMI, dietitian referrals, and midwife follow-up will continue. Change in the clinical setting is not possible without teamwork, and teamwork is what led to many of the project's successes. The past 8 weeks were exciting, exhausting, stressful, and rewarding all at the same time. But as a result of this project, I now have the confidence and skills to be a change agent in healthcare through quality improvement leadership. Thank you.
Perfect. So 5 minutes and 41 seconds. Nice job, Kristen. Let me just fill that in. Really nice job. Okay, Anne, my dear, it looks like it is you. Whenever you feel the moment is upon you. Anne, you're muted. Oh, there you go.
There, I think you can hear me now.
We can.
Okay, so Kristen, I totally would have been motivated by the lobster.
I know, I saw that and I was like, I am so jealous.
Yeah, no, I would have been into that. Okay. Okay, I'm ready.
Okay, go ahead.
Hi, I'm Ann Schaeffer, and this is my project on improving the efficacy of depression screening for Harrisonburg Community Health Center. We are located in the central Shenandoah Valley. This is a refugee resettlement area, and therefore we have an incredibly diverse community. Whoops, I'm sorry, that's not letting me advance. Sorry. Why is it not letting me advance?
Okay, we'll stop. You can start again.
Hang on, I do apologize.
No worries.
Why? Let me just make sure I connect there. That's what I want. Sorry about that again.
No worries.
All right. Okay, I'm so sorry. Thank you for letting me start again.
Of course.
Okay, here we go. Hi, I'm Ann Schaeffer, and this is my project on improving the efficacy of depression screening for Harrisonburg Community Health Center. We are located in the central Shenandoah Valley. This is a refugee resettlement area, and therefore we have an incredibly diverse community. Even though my specialty is women's health, my center's QI priority was to improve their depression screening and follow-up rate, which had been quite low for some time. Therefore, I found myself designing a project on depression and arrived at the aim to increase the efficacy of depression screening through SBIRT for screen-positive clients to 75%, and I needed to do it for a diverse, multilingual community. For plan changes, I needed to engage my team. I planned in-services, multidisciplinary planning meetings, held a contest to name the project, posted project updates, and shared patient stories. Teams also engaged in self-evaluation throughout the project. I wanted to engage patients in shared decision-making, and my team chose the option grid as the brief intervention tool to use. An incredible team of interpreters translated it into Spanish and Arabic, and later warm handoff education was also added in 3 languages. At my clinic, the PHQ was given verbally, but an interpreter shared her concern that asking the questions aloud is often not culturally appropriate and may be resulting in false negatives. I planned to trial written PHQs in 6 languages, and these were organized in so-called blue books and placed in exam rooms. Finally, a right care tracking log was created, and patients who consented to follow-up were entered. Chart audits, follow-up phone calls, and data on follow-up was collected to guide best practices. I predicted that over 90% of staff would receive education and teamwork scores would increase by 20%. For patients, I predicted that shared decision-making and documentation of choice of care plan would reach 90% and that appropriate depression screening would reach 100%. Finally, I predicted that at least 80% of patients would have evidence-based plans and that compliance with follow-up would increase to 70% or more. In terms of results, I'll start with my aim, which was met and surpassed, even achieving 100% on a few clinic days. To meet the aim, a patient had to be appropriately screened as positive, have documentation of shared decision-making, and a documented evidence-based plan of care. So how did we get here? Over the course of the project, 94.1% of the staff received training and education on depression screening, surpassing the goal. But working around summer vacations and staff turnover was a challenge, which was also caused a drop in teamwork evaluation scores. A consistent 20% increase was not achieved. Meet Nellie and Laura, 2 clinic staff. They have stopped in at a breakfast to celebrate the project halfway point. This provided an opportunity to educate, update the team, and provide them with new screening triggers. Both providers in this project became successful in documenting the patient's choice of care plan, surpassing the goal, and even reaching 100% on several occasions.
And
yes?
your slides are not advancing.
They're not?
Nope. I didn't want to stop you, but I couldn't bear it. You've done such a good job.
Oh no, it is on my end.
Is anybody else seeing these slides advance? No.
Oh, I am so sorry.
That's okay.
I've done this before.
You know what? We can do it one more time. And if you have to, let's try it one more time. I'll leave my mic on so I can stop you. But if we have to, you can leave show it. Do not the full screen.
Yeah, but I've done that. I've done this before. Okay, hang on. Let me just. Okay. I'm not quite sure what the deal is here.
It's because you're presenting. That's what the deal is.
I'm sorry for all of you that you have to keep listening to me. Okay. Let me just see.
You had to listen to me out of breath, huffing and puffing. So what are you gonna do?
You're being really kind. Okay. Okay. So I have to.
So you're not on review, are you? You're not doing the timed one?
No, I'm not. No.
Pull it up. Try again.
Okay. I'm wondering what. Okay. All right, it's on my screen, but I have a feeling you're not seeing that at all.
Nope, we see you.
You see me. Okay. So let me just try. All right. I mean, here's this.
Yep. Now, if you have to, you can leave it there and just go through.
It's just so lame.
That's not the best.
It's not my preference. Does that work?
I can still see you're not in present mode. I can still see your slides on the left.
Okay. All right.
But if you go to full screen, I might not see them.
Okay. I
think you need to go from current slide.
Okay, if I do that.
And now make it full screen so we don't see the slides on the left.
It's full screen for me. I
can't remember because I'm not in it. Kristen and Caitlin, do you remember?
What am I doing wrong?
Are you actually screen sharing with us?
It says I am.
I see it. Do you guys not see it?
Yeah, I see it.
And when you push that from start, little curled over arrow, what happens?
So it goes to full screen for me. But it must not be looking like that.
What if you go over for like the settings for two displays over on the right, all the way to the right, because it's in presenter view.
No.
What about broadcast show to the right of from current slide?
Hang on.
Custom. Maybe you need to do custom. Maybe you need to, I don't know.
I don't know either. Okay, hang on a minute. Let me try one more thing here. Okay.
I have to be doing it. I can't, I'm not much help when I'm not doing it. I'm thinking if you did custom,
Okay, let me set up the show. Browse an individual window. Okay, I'm gonna screen, let me get out. Okay, let me screen share, application window. Let's try that. Okay. So does that?
That works.
You can see that?
Yep.
It's just not quite as, let me see if it'll just, okay, if I do that, does that advance for you all?
You're on slide 3 right now.
Okay, 1, 2, 3.
No.
Do it the way you did it before. It looked good.
Okay, that's just a different, I mean, that's okay. It's just.
I think we go with it. But right now the slides are not advancing.
At the bottom left.
Now they're advancing.
But here they do.
Now they are, yep.
Oh man, okay. Well, I am
Up
sorry.
to the first one, that's okay.
I'm sorry it's not gonna be quite as pretty.
You go ahead when you're ready.
Oh my word, okay. Thanks you guys. Whew. All right. As you know, I am Ann Schaeffer, and this is my project on improving the efficacy of depression screening for Harrisonburg Community Health Center. We are located in the central Shenandoah Valley. This is a refugee resettlement area, and therefore we have an incredibly diverse community. Even though my specialty is women's health, my center's QI priority was to improve their depression screening and follow-up rate, which had been quite low for some time. Therefore, I found myself designing a project on depression and arrived at the aim to increase the efficacy of depression screening through SBIRT for screen-positive clients to 75%, and I needed to do it for a diverse, multilingual community. For planned changes, I needed to engage my team. I planned in-services, multidisciplinary planning meetings, held a contest to name the project, and posted project updates. Teams also engaged in self-evaluation throughout the project. I wanted to engage patients in shared decision-making, and my team chose the option grid as the brief intervention tool to use. A great team of interpreters translated it into Spanish and Arabic, and later warm handoff education was also added in 3 languages. At my clinic, the PHQ was given verbally, but an interpreter shared her concern that asking the questions aloud is often not culturally appropriate and may be resulting in false negatives. I plan to trial written PHQs in 6 languages, and these were organized in so-called blue books and placed in exam rooms. Finally, a right care tracking log was created, and patients who consented to follow-up were entered. Chart audits, follow-up phone calls, and data on follow-up was collected to guide best practices. I predicted that over 90% of staff would receive education and teamwork scores would increase by 20%. For patients, I predicted that shared decision-making and documentation of choice of care plan would reach 90% and that appropriate depression screening would reach 100%. Finally, I predicted that at least 80% of patients would have evidence-based plans and that compliance with follow-up would increase to 70% or more. In terms of results, I'll start with my aim, which was met and surpassed, even achieving 100% on a few clinic days. To meet the aim, a patient had to be appropriately screened as positive and have documentation of shared decision-making and a documented evidence-based plan of care. So how did we get here? Over the course of the project, 94.1% of the staff received training and education on depression screening, surpassing the goal. But working around summer vacations and staff turnover was a challenge, which also caused a drop in teamwork evaluation scores. A consistent 20% increase was not achieved. Meet Nellie and Laura, 2 clinic staff. They've stopped in at a breakfast to celebrate the project halfway point. This provided an opportunity to educate, update the team, and provide them with new screening triggers. Both providers in this project became successful in documenting the patient's choice of care plan, surpassing the goal and even reaching 100% on several occasions. What made the difference was creation of a positive PHQ template in eClinicalWorks, which prompted the correct documentation. Our population has many risk factors for depression, so I was not surprised to find that the positive PHQ rate in our clinic is not the 16% from baseline data, but closer to 50%. One challenge is that halfway through this project, the care coordinator abruptly resigned. Until new processes were put in place for pre-visit planning, a drop in the rate of identified depression was observed. Starting in cycle 2, chart audits were conducted on kept follow-up contacts. Using guidelines from the U.S. Preventive Services Task Force and the CCNC Toolkit, providers were documenting right care for patients most of the time, but compliance with follow-up had a baseline around 40%. This outcome is now reaching 62 to 80% and will continue to be tracked until early October. A deeper look at the tracking log data showed that about 68% of clients consented to follow-up. Of these, 13.3% or 6 patients have transitioned out of the log due to remission of their symptoms. While a small number, it's encouraging given the relatively brief length of this project, and I hope to see that number increase. 39 patients remain in the log for ongoing follow-up at this time. To summarize, the timely screening of depression revealed increased prevalence in this population. Intentional patient engagement seems to improve screening and follow-up and may result in faster remission of symptoms. Team commitment was consistent throughout the project, although sometimes challenged by staffing turnover and summer vacations. But overall, the project aim was met. During this project, I learned that screening drives chronic disease care. When the screening rate dropped, fewer patients with depression were identified and fewer received appropriate referral to treatment. I learned that perception of effective teamwork is affected by daily variations in staffing and pre-visit planning. And finally, when patients are engaged in their care in culturally appropriate ways, improved compliance with follow-up and remission of symptoms are more likely to occur. In terms of impact on the system, depression is much more prevalent than previously thought for the entire community and needs to be screened, treated, and managed like any other chronic illness. This project demonstrates that multidisciplinary teams can bring about great change, and this implementation can be used as a model for other primary care settings and should help grow the behavioral health services at HCHC. In conclusion, it is promising that the screening process, understanding of right care for follow-up, and the use of shared decision-making have all been improved for 2 care teams. With coaching and resources developed by this project, other care teams at HCHC can begin to implement right care for depression. Tracking for positive PHQ patients should continue, but will benefit from an eventual transition to an electronic method that works with our EHR. As I reflect on this project, I realize I've come a long way since the last time I was a Frontier student. I also know that the faith that HCHC had in me as a DNP leader enabled me to take on this project and succeed. I have become a fan of multidisciplinary teams. For example, the internal name for this project was chosen by a billing assistant, the SMILES project, which stands for Screening More Individuals, Less Emotional Stress. When I began this project, I could not see the destination, but my site believed in me and I believed in my team, and now I know that we are prepared to take better care of those in our community who are the most vulnerable. Thank you. You're muted still.
I said nicely done, just under 6 minutes.
Ugh. Well, I'm so sorry about the technical
That's okay.
difficulties.
You know what? I wish I could have helped you, but when I'm not doing it myself, and really it is just punting and going to see what you can find when it's not working.
Well, and I've done these a lot this term, so I don't know what step I was missing, but something.
And honestly, I swear sometimes you just have to turn your computer completely off and it resets. No, you know, it really, when it reboots, it puts everything back to where it's supposed to be, but that's okay.
Okay.
So you know what?
Thanks.
We all, it's good. It's good to go.
You heard it like 2.5 times.
That's okay. All right. So let's have everybody take your, or take them off as you want to. Let's discuss your projects. Let's discuss, you know, now that you're finishing up, so Ardith and Emily, these guys they've just submitted their last PDSA form, and they just have their summary, these Pecha Kuchas in their summary, and then, you know, silly little things to be done. Where have you come, and what have you really learned? I mean, we have 2 730 students here. So let's see if you could each give them 1 or 2 pieces of advice that you have learned. That would be great. Because I think it would be really interesting for you to think back and say, where was it when I came and I started here and I felt so lost, and what have I learned?
I think one of the biggest things I learned was actually from your advice. I think it was in Nisa's at the very beginning, and that's that in the beginning, it's really going to be chaos and it's going to feel like chaos, but that's okay because that's how things are built. That being said, as much planning as you can do between your terms is really going to help you start off not feeling crazy.
Okay. Thank you, Caitlin. Anne and Kristen, anything?
Yeah. Honestly, my biggest piece of advice is to, and hopefully you're doing this, do a project that really matters to your site, and try to get buy-in from as many people as possible. I can't tell you how much more smoothly my project went because my site wanted me to succeed. People were pretty enthusiastic. All those things you do with the fishbone diagram and the patient shadowing, they're all going to inform the process changes, and you will go back to those things. I made a change in my 3rd PDSA cycle because I went back to my fishbone diagram and I thought, what have we not addressed? And there were things from way back in April that we could still do. So really helpful.
And why did you do that, Anne? Had you met 100% of where you were, so you had to keep going?
Yeah, it was my screening ramp, and we were at a really good, it was patient engagement ramp, and there wasn't a lot more we could. It was hard. I was a little stuck on what else I could change at that point. We were clicking along pretty well, but then I did realize that we had not addressed warm handoff education. There's again, some of my team had suggested that a lot of patients, especially from different cultures, are very confused by the warm handoff concept. They're like, you're my provider, why aren't you taking care of me? And they tend to not go. They tend to no-show because they feel like they got passed on instead of handed off in a warm way. So that's what we did. We sort of revisited that and shored that up a little bit.
And did you have several meetings along the way with your team?
I did. I had several meetings. I had several meetings during 730, and I had several meetings this summer with different configurations of my team. You know, people would be away or in and out or whatever, but you know, I just took who I could get, and I also continually updated every 2 weeks. I had new posters, new PowerPoints that were in the bathrooms and on cork boards, and like everybody knew what I was doing. So it was really, yeah, people were really in the loop.
Great. And what about you, Kristen?
I would say, to kind of repeat what Caitlin said, looking back, it is okay to feel like everything's chaotic and that you're lost. Doesn't feel okay at the time, but looking back, it is okay. Also, I would say in the beginning of my project, I was doing a lot. I was handing out the goal worksheets. I was doing most of it, which actually was the best thing I think I could have done, because once the MA started saying, oh, the patients are really excited about this, they started getting excited. And they were okay with introducing the tool, and they were actually really good at it. So I think just not being afraid to start doing things yourself, but also make sure you include others and giving others the responsibility too. And most likely they'll be more excited about it if they've seen it done.
So demonstrating for them and then giving a little bit of ownership to all of the different members in your team.
Exactly.
And what about your team? I mean, did that concept change, morph, spread, move at all? Did different people become part of your team? Did your team encroach out a little bit, or did it stay the same?
Well, my team, I work for a really small office, so it stayed the same.
Uh-huh. Okay. Joni, any comments? Any thoughts?
Well, I thought you all did very well. What were the time? I missed the time on the first one, Judy.
The time for each?
Mm-hmm.
They all were under, one was a little over 6. They can be 6:40. I have it right here. The first, let's see, Caitlin was the first one. Caitlin was 6 minutes and 37 seconds.
Yeah, great. No, I thought you all did fantastic. I thought your slides look good. I feel your pain, and I've been there before to where I'm doing a presentation and I just can't make those darn slides do what they're supposed to do. But Anne, I want to shout out, is going to show up at DNP Bound virtually next week. And so she gets to do this again.
I'll make it work, I promise.
I think there are going to be, there's 30 students on site and another 34 or 35 companions joining virtually. So you'll have a really big audience, and you'll have it perfect by then. So
it'll be fine, I swear.
All right, well, let's move to Ardith and Emily. Do you have one question each if you could have one question for these guys, what would it be?
I know Ardith was going to ask something right before we started a presentation.
Ardith, you're on mute. There you go.
Yeah, it's done slipped my mind. I've got to reinvestigate the crime scene here before I can remember what it was, because I was watching the presentations. But I guess I'm feeling the way I should be feeling, according to you ladies, and you all did a wonderful, wonderful job. And makes me feel there's hope for me, because things do happen when you present, you know. So I just hope that I see the big picture here before much longer.
All right, Emily, do you have a question?
Yeah, I'm curious how your balancing measures, how that ended up in reality once you started your projects, and if there were anything that came up that you did not expect that was difficult during the project.
Okay, that's a great question. First of all, I had to change my balancing measure really early on, because my balancing measure was going to be cycle time for patients in the building, which I thought would be absolutely no problem to track. And literally the week before we started with PDSA 1, our eClinicalWorks, our EHR developed a glitch where it would not track time. And so you just can't control that. That's real life. And so that's QI. So I quickly changed, and I kind of defaulted to one that you guys can do. That's not, it's a little bit low hanging fruit, but it's how much APRN time you're spending on your project, because you're tracking your hours anyway. So I spent 241 hours on my implementation. I know that. I just put that on the staff update today. I was like, y'all need to know this about me. So that was one unexpected thing. The other unexpected thing was when my our center's care coordinator resigned. And that was really abrupt, because we knew she was probably leaving, but she left quickly. She was doing all the pre-visit planning, which is what in our chart notes would usually cue us to do depression screening. So I had to really quickly scramble for myself and the medical director, who were the two providers in this project, And I started doing pre-visit planning for the two of us, but I quickly got a bunch of other screening triggers together for the staff so they could like have easier ways to know if somebody needed screening. And it was just really interesting because I didn't anticipate that. I saw my screening numbers dip way down and I was like, oh no. But it also was a point of learning because I learned how much screening drives the whole process at that point.
And you worked with IT to get those up and running?
To get which part up and running?
All of your screening cues?
We did sort of a mixture. We had I wrote the positive PHQ template, and which actually was not difficult. I know with some EHRs that's a real pain in the butt, but it was really not hard for my system. And I was doing manual chart audits, but most of what I did with the teams where I gave them a combination of like I made little laminated like cards that they could put on their badges that would tell them how to find the last PHQ. I had like little smiles sticker triggers that I stuck on their laptops. I sat with them. I sat beside them in clinics a lot when it wasn't my team. I just showed up at their clinic and hung out and brought them coffee and then made sure they could find. So I did a lot of on-site coaching.
Mm-hmm. Great.
Yeah. I also really liked run charts. Actually, I hope that's something you guys will get excited about putting. Am I wrong? Did you guys enjoy putting your numbers on run charts? Wasn't that kind of fun?
It was fun.
Yes, it's cool.
That was good. The Excel's a little frustrating. I think if you can learn as much about Excel as possible beforehand, you'll be in a better place.
Well, and I think this group especially, we had unfortunately several versions come out, and that got people crazy. I think that we are going to stick to the right one this time through IHI and not even offer any other versions, because people got, if you're not good at something or really adept at Excel, to have several versions come up that none of which you can fix when things don't go right is just infuriating. So I think that was a specific glitch in this group. Because we had some lovely people who offered, and that's a lovely thing, but I think it really made life a little bit difficult for some people. Okay, what about Kristen or Caitlin? Anything about balancing measures for Emily?
My balancing measure was team satisfaction. So I got my baseline data, and my measure was I didn't want to see it decrease below 10% and actually increase, which was nice. And then as far as anything that I didn't expect would happen, well, not that this wasn't expected, but where at summertime, there were a lot of vacations. So I guess the importance of just keeping everyone in the loop and communicating well, because that was kind of difficult.
And did you find, Kristen and Caitlin, did you also find that teamwork was very key to what you were doing?
It was probably the most important thing.
So I tell everybody that every time and nobody believes me. That's why I want it on tape. I want it on record that it's not just me.
Yeah, like I said on my presentation, nurse education and their willingness to work as a team, and the lactation consultants' willingness to work as a team, that was the only reason that this project succeeded.
And I can't remember which one of you that said, you worked from the bottom up, that everybody had to, you really had to start with the ground level, include everybody, and go all the way through. I thought that was also a really important point.
And really simple things too, that you don't, you almost, when I was doing my 30 to 60 second huddle board education every day, sometimes I would do things that I'd be like, I would hope these nurses aren't offended by how simple this is, but they weren't, because they're either old, they're old and they hadn't heard it for a while, or they're new and they hadn't heard it enough, or they just needed to hear from the managers that were doing huddle, that were in charge, that it was okay.
Great.
Was it pretty challenging, Caitlin, having that, such a big group of nurses? Were they receptive to what you were teaching them?
I didn't have time to Pecha Kucha, but I almost it, like many, this project even started, I thought, I will just scrap this term. I will take a term off. I will redo the planning term and do an easier project at my super small FQHC, because I was working with hundreds of nurses. But you know, I have really good rapport with the nurses, and I've worked really hard on that in the years that I've been there, because it didn't used to be that lactation had good rapport with the floor nurses. And so that really, really helped. And like I said, the administration being there when huddle was happening and nodding their head yes to the education that was being provided was really the clincher, I think. But yeah, it's so hard to work with so many nurses. So hard.
We did have a student last term, I think, who was doing a similar thing on labor and delivery. And so a lot of very strong-willed, a lot of nurses. And at one of her early meetings, she had morning meetings as well. And one of her morning huddles where they would go over the whiteboard, and she was working on C-section rate, the CEO came down, and someone also a high-level person. And same thing, they were so interested in what she was doing and how she was doing it that they started coming very regularly. And talk about inspiring your team. That does seem to mobilize things a little bit. All right, great. Well, listen, I don't want to keep you. We only have 3 of you. I'm happy to stay on if there are questions from the 3 of you. And wonderful presentations and such a good job. And I hope you have a little bit of a breather here when get your summary done, and then a little breather so that you can regroup. And I think, Caitlin, I don't think you were on when I was saying it's a great idea to download the Squire guidelines, to look at them and put them away, and to just sort of let things percolate a little over these next 2 weeks so that you can really start to think about, I think it takes a little time to think about your conclusions. Like, what really was the conclusion of all this? Not the results. It's not a rehashing of the results, but what do I really feel? Like, what affected what, and what correlated with what, and what associations can I make? And then ultimately, what do I conclude from doing this? So I think that it's a good to look at that, ponder it, and then let it percolate for the next few weeks until you begin to write. All right, Dr. Slager, anything else to add for these ladies before we go?
No, I'm incredibly proud of all 3 of you. You've done a great job. So I know that the implementation, for those of you in PC 730, the implementation is harder work as far as boots on the ground work, but I think it's a lot more fun than the planning. So those of you that are in planning, you can look forward to next term. And those of you that have just completed a really demanding, busy term, you get some well-deserved rest. And then in a few weeks, you'll start writing.
All right, everybody. Well, I'm going to adjourn unless someone has anything else to add. This will go up onto the sign-in sheet as we always do, so you'll be able to go back and look at it. And congratulations again. Super impressed with everything you all have done. Really, jobs well done. And you know, you can really tell that you guys put in 240 hours. I mean, you can tell that you put in a lot of time with this, and really nicely done.
Thank you.
Great job, everybody.
Thank you very much.
I'm going to stop the broadcast.